to make sure your every breath is safe. We look forward to seeing you again. When the world comes to a halt, Taiwan keeps on preparing to make sure your every breath is safe. We look forward to seeing you again. When the world comes to a halt, Taiwan keeps on preparing to make sure your every breath is safe. We look forward to seeing you again. When the world comes to a halt, Taiwan keeps on preparing to make sure your every breath is safe. We look forward to seeing you again. When the world comes to a halt, Taiwan keeps on preparing to make sure your every breath is safe. We look forward to seeing you again. When the world comes to a halt, Taiwan keeps on preparing to make sure your every breath is safe. We look forward to seeing you again.
we start, I'd like to invite Vici Lula.
Yeah, please enable start sharing video.
Check. Nói trôi ban mình đấy, ông chờ lưu xử lý được mong năng ba đi.
Hello, good evening, everyone.
Good evening.
Hello.
Good evening, Fernando.
Good evening. I think and you need to release the camera. The camera is stopped by the host from the VT Healthcare.
Yes.
You cannot enable the video.
Yeah. You cannot open the video.
So I'm also.
Yes, because they is blocked.
Video. Yes, in VT Healthcare.
It's VT Healthcare is locked the video.
Yes, they are doing.
Okay.
Okay, you can check.
Now
Okay. Good. Okay. Invite Vici Luna.
Yes. Okay, starting now. Can I start now?
Yes, sure.
Yes, you can start. Sure.
All right. Good evening and hi everyone. This is CPD Asia. We are on the 4th online continuing professional development platform for Asian Radiologic Technologists Societies. Hosting this event is the Taiwan Association of Medical Radiation Technologists. And in helping us organize the Asian CPD, all member societies are grateful to VT Healthcare Vietnam and Bayer Vietnam. To formally start the program, please welcome the Taiwan Association of Medical Radiation Technologists, TAMRT President, Yu-Xuan for the opening remarks.
Okay, thank you. President Subiato, President Guo, President Kim Woo-Tin, President Banares, President Tai, President Sophia Lai, and President Win. Invited speak, ladies and gentlemen, good day. It's a glorious moment to extend my warm wishes on behalf of the TAMRT. I want to convey my heartfelt gratitude to all society for interventing TMRT to participate Asia CPD. It's an opportune moment to refurbish and debate on the current problems in radiology field by sharing our research and clinical experience through this platform. Before we begin this seminar, I would like to express my heartfelt gratitude to all of you who sincerely committed to this event to make it a success. This event would have been impossible without the support of each and every one present here. Thank you. Patrick, please open your microphone.
Thank you so much again, President of TAMRT, President Chun Yuan Tu. Ladies and gentlemen, participating also with us tonight are the presidents of the different RT societies and associations, the host of the first CPD Asia Macao Radiological Technologist Association's MRTA President Fernando Koch.
Hello, good evening, everyone.
The second host of the Asia CPD Indonesian Society of Radiographers, also known as Rex Sugianto.
Good evening, everyone. Hello.
We also have a president of the Vietnam Association of Radiological Technologists, President Thai Van Lo.
Good evening, everyone. Good evening. Good evening, everyone.
We also have tonight the Cambodian Radiological Technologist ACRT President Sophie Lee.
Hello, everyone. Hello.
And the president of Hong Kong Radiographers Association, HKRA, President.
Hi, everyone. Good evening.
And representing the part for Sir Rolando Banaras, I am hosted by the TAMRT, has prepared for us 3 expert speakers. Let us now start to experience sharing of medical imaging, development, and clinical practice in Taiwan. Please welcome the CPD Asia TAMRT Program Moderator, Mr. Cheng Willie.
Hello, good evening, everyone. Ladies and gentlemen, good evening. So my name is Chen Hui Li. I come from Taiwan Association of Medical Radiology Technologists. So today I am honored to be the host of tonight's meeting. In order to make today's meeting go smoothly, each speaker has 50 minutes to present, and after all speakers finish their presentation, then we will have 30 minutes for your question. So maybe we can start to tonight's presentation. Now, let's welcome the first speaker of this section, TAMRT, Yu-Xuan Lin. He comes from Chimay Hospital, the Department of the Radiological Diagnosis. Today, he will share a clinical experience of MR imaging technique, and his topic is MR Enterography in Crohn disease, preparation and expectation. So maybe we can begin. We can start today's presentation. Hello? Hello?
Hello everyone, good morning and good evening. Dear distinguished guide and officer, I appreciate the opportunity to be here with you today. Is everyone ready? It's about time to start this presentation because it looks like just about time, so let's get started. Before we get started on this presentation, allow me to briefly introduce myself. I'm a technician with radiology in Chimay Medical Center, and I come from Taiwan. As you can tell, English is my second language, so I'd appreciate your patience with my not so perfect English. As you know, the reason we are here today is to discuss how to preparation and expectation in MR Enterography. When we went to application in Crohn disease, I'd like my talk into 3 parts. The first part, I will start off my course of Crohn disease. In the second part, I will then go to talk about when we start and duration this program, how we can do for patient or ourselves. And in the final part, I will giving you about this program contraindication and discussion. So, in the United States, the number of people suffering from Crohn disease increases each year, both in children and adults, which will also result in an annual cost of 56.3 billion. And on this chart, you can also see that in the world, because of the quality of living environment and economic progress, resulting in an increase in the number of people sick year by year. In general, the inflammatory bowel disease encompasses to idiopathic, chronic, and inflammatory disease, and they will be divided to parts. The first part is Crohn disease, and the second part is ulcerative colitis. It's worth mentioning Crohn disease and ulcerative colitis are disorders of unknown cause, involving genetic and immunological influence in the gastrointestinal tract's ability to distinguish foreign from self-antigen. However, important pathology and clinical difference that distinguish this inflammatory disease process. In clinical, Crohn's disease tends to present more frequently with abdominal pain and perinatal disease, where ulcerative colitis is more often characterized by gastrointestinal bleeding. Cobblestone mucosa and ulcers or linear ulcer characterize the endoscopic appearance of Crohn's disease. Ulcerative colitis presents with diffuse continuous involvement of the mucosa. Radial study of the patient with Crohn's disease characterized show fistula and symmetry and ileal involvement. In contrast, radial study of the patient with ulcerative colitis show continuous disease without fistulae or ileal disease. Pathologically, Crohn's disease features mucosa discontinuous, transmural involvement, and granulomas, where ulcerative colitis does not. Especially, cryopsis and granulomas are present only in Crohn's disease. Just mentioning in the next slide, there is a similarity between inflammatory bowel disease. In addition to about this question, we can also distinguish from where. In general, cobblestone and sugar polyp can usually be seen in the colorectal scope. Here we can see the intestinal wall is smooth relative to normal colorectal minor, but uneven under Crohn's disease and ulcerative colitis. So overlap, they share many overlapping epidemiological, clinical, and therapeutic correlatives such as arthritis, eye disorders, skin problem, kidney and liver disease. In some patients, it is not possible to distinguish which form of inflammatory bowel disease in some present. Because of this, we usually arrange some medical program for undiagnosed patients and we want to check their blood test, blood pressure, body temperature, and respiratory rate and body weight to rule out whether it is just a common abdominal disease. However, even we can usually use the physical examination in the first place to confirm that the patient is suffering from Crohn's disease. It's like fecal corporating, but we all know that the medical diagnoses are not diagnosed by a single test. An endoscopy such as esophageal gastroduodenoscope and ileocolonoscope do not fully observe the entire small intestine, and it is easy to overlook the distal ileum and submucosal layer and messenger region. What's more interesting here is that the detection rate of the fecal coprostatin can be almost confirmed but not certain, because there is no perfect texture in the world and can only be verified continuously. In general, Crohn's disease usually have the colitis of skin lesion and are prone to disease at the terminal, and it can pass in the intestine, repeat tube, or clog the affected organ outside in the intestine. For some patients with Crohn's disease, it can produce some symptoms such as eyes, blood, system, and joint, before the appearance of gastrointestinal symptoms. So the history of some patients before the diagnosis. Imaging examination is really important because those results can provide some important information to support diagnosis, and it can also confirm the severity and activity of the Crohn's disease. So in this slide, we want to show you guys, you can see in the past, two systematic review papers have reporting that the sensitivity and specificity of MRE or CT to Crohn's disease are nearly 90% in each layer. In making imagery program is so indispensable. So before we need to start the examination, how do we do? The first step, patient were asked to follow a 4-day residue-free diet and 4-hour fast. Before the examination, we were given a hyperosmotic oral aqueous solution. It was mixed with dilute sorbitol at 70% to be taken over a period of 40 minutes to 60 minutes. In the meantime, if the patient is able to walk, we hope the patient can move a little bit, forcing the gastrointestinal tract to move so that the patient can feel the entire intestinal more. When time arrival or the patient wants to go to the toilet, we can get the patient into the examination room. During the patient was in a prone position, and if the patient have any contraindicated, we were usually given a body weight based dose of buscopan, and it were administered intravenously before the contrast agent to obtain blood relaxation or peristalsis reduction. In here, I would like to make sure that the portion is filled in the intestine before we given the buscopan. Gadovist was used for all patients at the recommended dose of 0.1 ml per kilogram, followed by a saline flush. When we finish this program, we usually educate patients about healthy advocacy. It is easy to go to the toilet within 2 to 3 days of completing the abdominal suddenly sharp pain. Please back to the hospital and hand up images and inform that the enterography has been performed. We use the protocol provided in the literature as a reference, and at the same time, we will modify it to become our standard protocol. Image acquisition is obtained with several sequences. Among enterography image protocol very significant due to difference in requirement and personal experience. However, certain basic elements are common to most Crohn's disease image protocol. Phase sequence capable of acquisition T1 weighting and T2 weighting image in a single brief hold are crucial for obtaining diagnostic image and reduction of the artifact. In our practice, we use the 1.5 Tesla magnet to equip it with a phase array F element coiled with a following sequence. In here, we want to share some acute imagery for your reference. we just start with the histology and the intestinal wall thickening. By far the most serious of the patient we examined were imaging for star sign. It is mainly connected by multiple benign feet from tubal screening. In all conclusion, we'd like to remind you again, this program is not recommended when the patient's intestinal are broad or narrow or has a dysphagic disorder, as highly permeable oral medication can force the patient to develop acute abdominal pain and intestinal necrosis. In addition, this program is a much needed patient-related test within an MRI, especially between acute and non-acute patients. So in this program, how we can expectation in the future? Actually, we let patients drink about 2 liters of high osmotic solution before the examination. But usually these patients are like to rather younger and usually petite in size. So in all experience, maybe some patients can do the test by drinking only 1 liter solution. So maybe in the future we can measure how much medicine or patient should drink by weight or size. So this is my short-term topic. Thank you for your attention. Thank you.
Hello.
Okay, thank you for Mr. Lin's presentation. Now let's turn to the next speaker. Okay, artificial intelligence technique has become a very important part of medical imaging in the past few years. And with the application of populated software, so we can greatly increase the diagnosis accuracy of clinical disease. The next speaker, TAMRT Chao-Hsiang Chen from Taipei Medical University Hospital Department of Radiological Diagnosis, and he will bring us the experience of the artificial intelligence software used for brain imaging. And his topic is validation of the accuracy of rapid artificial intelligence software in detecting of large vessel occlusion in patients with acute ischemic stroke.
Hello, everyone. I'm Chao-Hsiang, a radiographer in the Department of Imaging Medicine at Taipei Medical University Hospital. I would like to give you a presentation about the research I'm working on currently, validating the accuracy of rapid artificial intelligence in detecting vascular obstruction in patients with acute ischemic stroke. In this research, a validating study was performed in Taipei Medical University Hospital to evaluate the accuracy of rapid artificial intelligence software in identifying the location of large vessel occlusion. In Taiwan, cerebral vascular disease ranks as fourth of the top 10 causes of death, and the stroke constitutes the majority of them. There are 2 types of stroke, ischemic stroke and hemorrhagic stroke. Ischemic stroke is caused by blockage of an artery, and about 70% of stroke are ischemic. Hemorrhagic stroke are stroke that caused by bleeding, and about 30% of stroke are hemorrhagic. There are 2 treatments for acute ischemic stroke, RTPA and IAT. When a patient with suspected stroke is taken to the emergency room, a non-enhanced brain CT will be performed first. If alluvial is highly suspected, The patient will further have a CT angiography and CT perfusion studies. In TMUH, when we finish all the exams, all the images will be uploaded to a rapid server for further analysis. And you may wondering, what are the functions of Rapid AI systems? Rapid has three major functions: Rapid Aspects, Rapid CT Perfusion, and Rapid LVO Detection. Let me introduce these functions separately in the next few slides. Aspects can automatically identify regions of the brain and generate score to help physicians quickly assess patient eligibility for thrombectomy. Aspects will rate on a score of 1 to 10. A normal brain has a score of 10. The lower score indicated the worst case. Rapid CTP is computer tomography perfusion, which uses the blood flow wash in and wash out to assess the survival of brain cells. It can calculate the blood flow automatically to assess the viability of ischemic brain tissue. The third function, rapid LVO detection. CTA and LVO is also the subject of my study. It will automatically process CT scan and deliver clear, easy to interpret 3D CT images for rapid identification of suspect LVO. And it can also process hundreds of CTA images in a short time as well. The previous two functions of Rapid Aspects and Rapid CTP have been proven useful in many studies. Now, in my study, I would like to validate the accuracy of rapid artificial intelligence software in detecting of large vessel occlusion in patients with acute ischemic stroke. In this study, we collected the CT image of 155 acute stroke patients from our hospital and uploaded them to Rapid server for analysis. 145 of them were successfully processed by the Rapid system, and the data were further statistically analyzed. The software I used for statistical analysis was IBM SPSS Statistic 25. Sensitivity and specificity are the most commonly used measure of detection accuracy. Here you can see the formula for sensitivity and specificity. Sensitivity is calculated as the number of diseases that are correctly classified, divided by all diseased individuals. Specificity measures the proportion of negatives that are correctly identified. In simple terms, sensitivity and specificity are measures of a test's ability to correctly classify a person as having a disease or not having a disease. Basically, when we have higher sensitivity, the less LVO we missed. When we have higher specificity, the less misdiagnosis we got. This table shows the results of Rapid after analyzing the CTA images. In these 145 cases, 47 cases with no LVO have been identified by Rapid software. 68 cases with LVO have been identified by Rapid as well. The sensitivity was calculated as 0.85. The specificity is 0.723. False positive is 0.277 and false negative is 0.15. Apart from sensitivity and specificity, we also performed the ROC and AUC. The ROC curve describes the overall performance of the diagnostic modality across varying conditions. ROC analysis allows one to average the effect of different conditions on accuracy. Therefore, the area under the ROC curve can be viewed as the diagnostic accuracy of the technology. For ROC curve, the more the curve close to the vertical axis is true positive, the result is better. The AUC represents the area under the ROC curve. The more the value close to 1, the accuracy is better. When AUC equals 0.5, it has no discriminative power. AUC between 0.7 to 0.8 is acceptable. AUC higher than 0.8 means excellent discriminative power. This is the analyzed result of the 145 cases. The ROC curve was close to vertical axis and its AUC value was 0.787. However, it is found that rapid actually have some limitations and will cause the image cannot be successfully analyzed by rapid for extracranial vascular obstruction. Cases of poorly enhanced quality and obstruction in posterior circulation. For example, spinal arteries, basilar arteries, posterior cerebral arteries. In addition, severe stenosis and obstruction will both be considered as LVO. Therefore, we have further excluded totally 65 cases, which with such conditions we just mentioned from our original cohort, and 90 cases were left. Then, these 90 cases perform the analysis of sensitivity and specificity ROC as well. In these 90 cases, 26 cases with no LVO have corrected identified by rapid software, and 59 cases with LVO have corrected identified by RAPT2. This table shows the result of RAPT after analyzing the 90 cases CTA images. The sensitivity of 0.983, specificity of 0.867, false positive of 0.133, and false negative of 0.17 were calculated, and the ROC curve and AUC were also performed. ROC curve become closer to the vertical axis means true positive, with an AUC value of 0.925. The statistical analysis of the screened 90 cases showed a sensitivity of 0.983 and a specificity of 0.867. And AUC was 0.925, which is higher than previous data. We also noted that even for the original 145 cases that were not pre-screening according to the restriction of rapid system, the detection power still achieved a sensitivity of 0.85 and a specificity of 0.723, with low false positive and low false negative rates, and the overall AUC is 0.787. Although RAPID is not perfect, its interpretation can provide a good reference for radiologists and stroke team in a very short time, and it has the certain potential and value of being an important support tool in clinical. In the future, we will continue to collect more cases for analysis to increase our sample size, and we will compare the efficacy between senior and junior radiologists with rapid systems. Thank you for your attention.
Okay, now thanks for Mr. Chen's presentation. Now let's turn to the last speaker tonight. So tonight's last speaker is Hsin-Yu, come from TAMRT. She's a Taiwanese diagnostic radiographer who is specialized in medical imaging processing. And today she will bring us some review information in MR imaging, combined with neural network techniques. The topic of this presentation is a review of convolutional neural network on prostate cancer detection using MRI.
Hello everyone, thank you for having me. It's an honor to be here. My name is Hsin-Yu Jen and I'm a certified radiographer in both Taiwan and Singapore. And in today's presentations, I was thinking it would be quite interesting if I can share a literature review that I did and when I was studying my master's degree back in Scotland last year under my supervisors, Dr. Chung Wei's supervisions. So I hope you enjoyed these presentations and I hope you can learn something from this. So let's jump into the presentation. The title of the presentation is a review of convolutional neural networks on prostate cancer detections using MRI. So this is my outline. I will go through the introductions, background of AI, comparisons of past studies, discussions, and the conclusion. So I'll cover the problem needs to be solved here and the end of this review. So the problem here, as you can see right here, I acquired this bar charts from World Health Organizations. And this is the estimated age, standardized incidence and mortality rates worldwide in 2018. And prostate cancer here has the second large amount of people have it in this data. However, the mortality rate is relatively low compared to other types of cancer, which means that people who have prostate cancer usually have better survival rate. That means the early early diagnosis is kind of important. But in other types of cancer, we normally suggest patients to do the screening and to be able to have the early diagnosis. However, in prostate cancer, it's a very different story because there's a tons called overdiagnosis or overtreatment. Okay, so to avoid this, normally the clinician won't really suggest patients to do the screening. That means patient usually needs to have symptoms, or they suggest they suspect they have prostate cancer, and they reach out to the doctor and ask them to do the check for them. So they normally go through this. Doctors will ask about their patient family history, PSA testing. They would ask them to do the PSA testing, which is the prostate specific antigen, and digital rectal examinations. And after that, if they are suspected to have prostate cancer, they normally will be suggested to do the pre-biopsy MRI. The reason why they are suggested to have the pre-biopsy MRI is because biopsy is an invasive examination. So if we can use a non-invasive way to see if the patients have cancer or not, that can probably prevent some patients who don't really have cancers to do the biopsy. So yeah, the pre-biopsy MRI is usually read by experienced radiologists, and they're following this guideline prostate image for reportings and data system, in short, PIRATs. And at this stage, the benign and malignant lesions will be separated or will be understood at this stage. And the end of this study is I want to know if the artificial intelligence can be used in prostate cancer detections and diagnosis by using pre-biopsy MRI. And secondly, compare the past studies of prostate cancer using AI, and especially for the convolutional neural network models. And as a radiographer, I want to introduce this to you guys. So what is AI? So I do believe that you can probably see artificial intelligence in many places, okay? But what exactly it is? The original meanings of artificial intelligence, AI, is just simply describing using computer science for doing tasks for human beings. However, in recent years, normally when it comes to AI technology, there is a technique called machine learning usually involved. So in machine learning, it means that the machines or the things that you build usually have the process of learning in order to do the task for you. And within this machine learning, there are many types of machine learning. And the things that we are going to talk about, the convolutional neural network, is part of deep learning. And yeah, within this machine learning terms, there are different types of different ways of learning. For example, supervised learning, semi-supervised learning, supervised learning, and transfer learning. And usually medical supervised learning will be used a lot because it usually have better accuracy, usually. So this is the basic concept of machine learning. I won't go through everything because that might take me more than 10 hours to explain everything, but I'll just briefly go to the basic one, okay? So that says, what is machine learning? So machine learning, in short, is to find the functions represent the process from input to the target. Okay, so that say the input is here, the cat that I drew. Okay, and the target is the cat, C-A-T, the word cat. So the C-A-T, this word is actually not meaningful for machine, but it's meaningful for human beings. So we want to look for the relationship between the pictures of cats and the word C-A-T. And when we look for this function to represent this, that called machine learning, if that makes sense. The truth is, it is involving lots of math. Okay, so I'll just briefly introduce some of them. Remember the cats and the picture of cats and the word cats? Sometimes their relationship might not be linear, so we will have the activation functions here to describe if it's not linear. We will use activation functions here to make it close to the targets that we want to describe. And the whole thing, we call it logistic regressions. However, it only describes one element. What if we have many types of elements? So that will be a different story, okay? But this is just the basic one. And once we know the functions of it, we want to know that how's the difference between the targets and the input. By that I mean the predictions and the targets that we want to know. So there is there are two terms, loss functions and cost functions here, to describe how difference between the things that the machine predicts and the real answer of it, if that makes sense. So the number comes out, we'll call it the error. So for this error, we want to reduce the error because we don't really want to make the predictions and the real answer too far apart, right? So we want to make the error lesser. Okay, so this process called gradient descent. Okay, so if you are an expert of machine learning, please bear with me because this is the most basic one, and I know there are a lot more different types of methods to do so, but I'll just introduce the most common one. And when it comes to more complicated, for example, many layers, there's the way called back propagations is usually being used. So I hope that makes sense. Right. So the AI to prostate cancer can be implemented in many areas. For example, pathology, MR images, and multimodalities. But here I'll only focus on MR images classifications. And especially, and this is just because I'm a radiographer, I'm interested in this. But yeah, in this research in 2018, it compares to the traditional machine learning SPN to the CNN, which is what we are going to discuss today. So as you can see, the traditional ones and the CNN, CNN has the better accuracy, sensitivities, and specificity. So that's the reason why I chose convolutional neural network here. So what exactly is convolutional neural network? So it mainly involving 3 steps. First off, the convolution. Second, pooling. And lastly, the Foley connections. So as you can see right here, and you can probably see there's a 3x3 filter. It will go through the whole pictures of it and do the convolutions. And will then produce a new pictures of it. And it will come to this steps, which is called pooling. And as you can see, there's a 2x2 matrix right here. And pooling, the mostly used one is max pooling, which means that within this 4 pixels, the maximum amount of it will be recorded to the matrix that we going to make, which is right here. If that makes sense. And lastly, it will be the Foley connection. Sometimes they call it flatten. Okay, so at this stage, just now, the matrix will be pulled to a vector. Okay, a vector right here. This is how the CN looks like. So sometimes the convolution, poolings, and Foley connection can be repeated many times, and it really depends on what kind of architectures that the researchers use. And that's how the research goes, because they want to find a best architectures to tackle the problem. So the procedures of building machine learning usually looks like this: data acquirement, image preprocessing and training model, which is CNN that we discuss here, and model evaluations. So this is the data acquirement. They usually use, most of them use 3T MI scanner, but some of them want 2 of them mixing 2 types of scanner, and one using only 1.5T Tesla MI scanner. And in both this research, they say that mixing the 1.5Ts and 3Ts images won't be a problem. Yeah, they list it out. They say it in their paper. And the image types, mostly they use DWI and ADC. Yeah. And data size, the maximum data size here is 427. I calculated by patients. Okay, normally we won't really calculate this by patients, especially when it comes to AI. But yeah, I think it's the better way to quantify it here, because I'm comparing many research, 11 papers. So I think it will be quite easy. It will be easier to compare by patients. So the maximum numbers of patients here is 427, and minimum is only 23, which means that they have to maximize their usage of their data. So they use these cross validations to try to maximize the usage of data. It just like separates the data set to many portions, and it will just choose one of them as validation data, and the rest of them are training data. And here, as you can see, the blue bar separates to 10 small parts, and each of them will become validation data once, and others will become training data at least 10 times. Yeah, if that makes sense. So it will maximize the usage of the data. And the pre-processing here, I listed denoising, feature scaling, segmentations, and registrations. I'm pretty sure most of the radiographers knows this, and it is quite surprising. At least I was quite surprising that denoising wasn't a choice for them to use. However, after thinking a bit, I think the convolutional part is pretty similar to the denoisings. That's the reason. That kind of explain why they don't really use denoisings here. Feature scaling, yeah, they mostly use image normalizations and segmentations. Most of them use ROI crop, which is like they roll the code and to crop the image for them. And 2 of this study use manual segmentation. That's quite interesting. And registration, like most of them use registrations as well. So that's how it works. Okay, so lastly, the training models and results. Image augmentations, it means that it will change the form of the image, but not changing the label. So most of them use it, and it will make the machine be able to train more images. And the architectures here, you probably see some scary terms here, but they are mostly the variations of convolutional neural network. It can be the size of the convolution. Just now, the GIF that I made was 3x3, but sometimes they will use it, for example, 4x4 or even more. Yeah, so that's how different the architectures they use. They probably use the automated, and the results here are quite interesting. Most of them are pretty high. They can go up to, for example, here at AUC, here AUC 0.87 and 0.87 and 0.944, and the accuracy can go up to 97.5%, which is really high. Yeah. So the advantages of AIs on prostate cancer diagnosis are here. Achieves a good results with a small amount of patient data. You get an instant results. It can run 24 hours, give the consistency result because it's a machine and it's cost effective. So once you made it, you can just use it forever. And however, there are some potential problems of CNN models on prostate cancer diagnosis. First off, not enough study for prostate cancer grading. So just now, those 11 studies, only 2 of them made the grading, and most of them not really did the grading parts. They only classify the malignant and benign lesions. And secondly, not enough patient data for training grading prediction model, which is kind of truth as well, because we don't really have enough data to train the grading prediction model. That means that we don't really have enough study for it. And thirdly, overfitting is not discussed in the past study. So we can see the accuracies are pretty high, but none of them mentions about overfitting. Have they tested? None of them mention that. And fourthly, the decisions is difficult to explain. So normally radiologists being able to explain to you why they think it's a lesion, but the machine can't do it. But recently in the artificial intelligence area, there's a technique called Great Camp. They be able to visualize the decisions that, or the things that convolutional neural network is looking at. So that's probably can be a way to solve this problem. And lastly, the generalization is a concern. By generalization, it means that if I train the model with the data of Caucasian people, can I use it on Asian people? That would be a question. So yeah, that's a concern. So here are my conclusion. By using AI technologies, the detections of prostate cancers can be done faster and more consistency. And secondly, more than 10 past studies using MI and CNN model in prostate cancer detections are compared and provide to be useful in prostate cancer diagnosis. And this is my reference. And thank you for listening my presentation. If you have any questions, just feel free to ask me.
Okay, now thanks, Ms. Jen. Now, thanks to all the speakers for their wonderful speeches. I think now is the time for you ask a question. So just please feel free to ask question, or maybe you can provide us some your comment for our speaker tonight. Any question?
Okay, I have a question. I have a question for this speaker. I think that now from YouTube and the 500 Zoom and everybody, you transfer in all a question for in Zoom 1000 Zoom. I have a question for pre-speak today. I saw 3 topics interacting. I'm interacting 3 topics very new. The first, middling. I'm interested intestinal for you use MRI for the Crohn disease. Oh, very interesting. But I ask you, in Vietnam, most, for example, patients have a abdomen pain. Most of they choose the first, they choose the ultrasound, and after that the CT scan. I want to ask you, what patient, when patient you move, you choose for patient, you choose for patient in MRI. I think that in Crohn disease you use the MRI very good for patient. But I ask you, how we for example, before you choose the MRI, abdomen MRI for Crohn disease. How before you select by ultrasound or CT scan first? After ultrasound or CT scan, you see or patient have Crohn. You think you're not so you thinking Crohn disease is this patient. You move to MRI. The first question for Michelin. I would like to invite the Michelin answer first.
Okay, sure. So, dear moderator and chairman, we choose the MI to do this program because there are various modulator involved for the assessment of the small bowel, including CTE, just computer tomography, enterography, and ultrasonography, and other endoscopy techniques, just like capsule endoscopy and enteroscopy. But the MI provides a number of advantages over more conventional techniques for imaging for small bowel, and just like superior tissue contrast and lack of ionizing radiation are its major advantage over computer tomography. And the other side, the contrast enhanced fluoroscopy. So, furthermore, with a dynamic sequence, MI permit assessment for functional information and improvement visualizing of the entire board. So, lastly,
MR imaging may also use for patients with the contraindication. So to do contrast enhanced CT imaging, they including these who are pregnant and they with the radiological contraindications to iodinate contrast. So that's why we choose the MR to do this program. So that's all. I hope my answer will be answer for you.
Okay, I think in your protocol in today, your topic, your presentation today, I think all many countries want to learn from you. Everyone, I want to learn from you. Very interesting, very good. I think everybody want to learn. Everybody can go to in YouTube link today. We can learn again because we got the short time. We cannot not enough time for we learn. And I'm also. The second, thank you, Mr. Ling. The second question for Mr. Chen. AI for acute is ischemic. We know AI in radiology very important now. In 5 years, in next 5 years or 10 years, everything change. The first question for you, AI, your AI software is make you now is made in Taiwan. The first, the second AI, your research, you use how many hospital? Mr. Chen, I have a question for Mr. Chen. I use more. How many hospital in Taiwan now use the AI software for stroke now? And how long one case for AI diagnosis for accurate ischemic stroke? In fact, Mr. Chen.
Okay. The first question, how many hospitals use the rapid AI in Taiwan? As I know, only five.
Yeah.
But five hospitals use the rapid AI for the stroke. Yes. The second, how soon can the rapid AI can calculate the stroke CT image? About 5 minutes. 5 minutes. It's a very short time.
Most of us very important in your AI. I think very important for stroke center or general or another hospital. Sorry, I want to ask you.
Yes.
The important your AI software. AI software
Yes.
very important for in or general hospital or only stroke center. Or general hospital. Not popular.
Not popular.
Yes.
It as I know in Taiwan, I just know my hospital use the rapid.
Yes.
So let the other hospital I don't know. Sorry.
Yes, I know. Thank you. Okay, thank you, Mr. Chen. The last question for Mr. Xing. I have a question for Mr. Xing. Or you use AI for prostate cancer? The first time I hear. I like it.
Thank
you. Your last presentation you saw some difficult. I understand in your some difficult. Now you maybe now you still in machine learning.
Yes.
Not yet in deep learning. Okay.
Yeah. So basically, CN convolutional neural network is one type of deep learning. So this convolutional neural network itself is a type of deep learning. So yes, it is within the machine learning.
Yeah.
And yeah, so that's kind of, it's one of them.
Yeah.
And for machine learning, it can be separated to many types. And yeah, so it's really complicated. That's why I only chose convolutional neural network for my comparisons, because if I want to extend to many types, or, you know, if I really including those, for example, segmentations, well, I will probably won't finish the whole review. Yeah. So that's a very interesting topic. And yeah, to answer your question, yeah, CNN is one of the deep learning.
But difficult, you tell me difficult. I understand you. Difficult for you. You saw in many protocol, many different protocol. How many you saw in many one for 2020? You have 400 patients. How many hospitals you get data? Because I ask you. You make some different protocol in hospital, some hospital in different protocol. How you choose in data for clear data? The first question, the second question, prostate cancer. How you compare with that now? You compare with in diagnosis, radiologist. They have a long time experience. And your AI, how you compare with your research? How compare? Two questions you can answer.
Can you rephrase the second one? The second questions, like I didn't really get the second question.
Compare with radiologist diagnosis.
Oh, okay, yeah, okay. So, well, this is the pretty interesting part, because as you can see, I compare 11 papers. Yeah, as you can see in the presentations, I compare 11 papers because I want to know what is potential methodologies that I can do. However, there's one research which is really interesting in 2020, the latest one. They because I do believe that many countries have their own guideline, at least for radiologists. They need to have certain images to be able to diagnose the prostate cancer. And for European Association Urology, and this is that they have to use T1 weighted image, T2 weighted image, the ADC, the DWI, diffusion weighted image, as well as dynamic contrast enhancement MRI. However, in the latest one, the 2021, they tried to compare using all these 4 types of image, and they compared to using only 3 types of image, and they want to see which one get a better results. Surprisingly, when they only use 3 of them, they get a better results. So I think that's the most different parts when it comes to using AI and clinical, because especially in convolutional neural network, you can't really explain it in a clinical way. So yeah, and I personally believe that that's the part when it comes to try to convince other people, oh, just use the AI, but they can't really just accept it because it's hard to explain. However, it can be explained mathematically.
Yes.
Yes. So when it comes to talking to the patients, oh, you can trust this. However, you can't really just say that you can't just tell them that the machine see the things in the same way as human beings do. Yeah. So another potential way to solve this problem, because just now I have mentioned there is a way called class activation map. So that's a very new thing. When we use the convolutional neural network, we can implement this, and the machine will light up the parts that the convolutional neural network is looking at. So maybe potentially we can use it as an explanation that we can use this to explain it. But normally for now, they only just explain the whole process through math. So yeah, that's my opinion. And yeah, I think I pretty much answered your question. I hope I answered your question well. I'm not very sure, but I hope you, I hope I answered that question.
Yes, I understand. Because AI in the future IP change. But we research to AI. We will make many difficult. But we must go. We don't stop. We don't stop. We must go to AI, more. We make many difficult.
And I think this is a trend as well. So
yeah. Thank you, Mr. Zen. Thank you, Mr. Zen.
Thank
I
you.
will come more in Mr. Lee again. Mr. Lee continue. Thank you, Mr. Lee.
Thank you.
Okay, thank you for your question. I just have a little feedback about Lux's first question to Mr. Lin. I think the radiation dose is a very big issue. So in the hospital I work for in Taipei, MRE we always do for young people because they have to for Crohn disease. We always have to follow the disease again. So for young people, the radiation dose we have to conserve. I think this is very important. Yeah, this is just my little feedback.
Sure.
Okay. For Mr. Lin, I have another question. I think, in my opinion, Bascopa administration is necessary in MRE examination. And it is also listed in many references. In some papers, it even suggests that the Bascopa should be used twice in different typefaces. So how do you think about this? What is your opinion?
Okay, sure. Dear Chairman, well, I'm sorry to say sorry to you first, because I'm afraid I didn't explain that clearly in my presentation. So the first chance of the Bascopan to be administered is when we confirm the oral high osmotic pressure fluid is completely filled with the intestine. And the second point in time is before the dynamic sequence check is performed. So the time before between 2 points will be about 15 minutes or more. So by the way, the patient must be confirmed to have glaucoma or benign prostatic hyperplasia before administering Bascopan. So because Bascopan can use excessive eye pressure or the increased symptom of gland hypertrophy, so some invisible condition occur. So does that answer your question? I hope my answer will be answer for you. That's all.
Okay, thank you. So any other question?
Yes, I have a question.
Sure.
Okay, my question is about the second speaker, Mr. Chen, talk about the stroke in Taiwan to use a rapid software.
Yes.
As I know, the rapid software is very common to use in the USA and Europe.
Yeah.
I want to know about the protocol for the stroke patient in your hospital.
Oh, our protocol.
Yes.
Is non-contrast or have a contrast?
No, so the patient when is suspected stroke come from the right, and then the patient will be sent to your department, and then we will CT scan, PAN scan, contrast. What about that protocol?
Oh, they come our hospital first. We test. We do the non-contrast CT first, then put the image to Rapid server. Then the Rapid will calculate to calculate the CT image. Then we show the brain where is stroke.
No, I mean the protocol. So the patients for the Rapid can analyze. You must be do the PAN scan, the CTA, the perfusion, and what? Because before you have mentioned it, I saw is the point about the perfusion. So the older patient when they suspect a stroke, you must do the perfusion in your hospital, right?
Right.
Okay. So when the patients come from the plain scan, and then you see the hemorrhage, so the calculator will be stopped. Okay, when the plain scan is a negative, so you will do the CTA and the perfusion, right?
Right.
So the rapid will be used three phases for the calculator. The first is the plain scan, and then the perfusions, and the last is the CTA, right?
Right.
So before I have the rapid software represented in Macau to come to my hospital, because we will care about the radiations for the patient to do the perfusions nowadays. So our hospital radiologists don't like the patient to do the perfusion, just only the CT is enough, or the MRI for the PWI like that. So the question is the patient must be do the perfusions for the rapid software, right?
Mm-hmm.
Okay. Thank you. I want just to know about the patients must be do the CTA and CT perfusions.
Yeah, in our hospital, when a stroke patient to the emergency, must do the non-contrast CT and the contrast CTA and perfusion.
Okay.
Need to do the all.
Okay, because it's a different. Just only I want to know about the other hospital like you. In my hospital, we never do the perfusion nowadays because the radiation is too high. But the neurologists and the radiologists, they don't have a rapid software like you, but they can decide what is the process we do.
We can decide if the patient need to do CT or not. Just doctor decide that. So we just do.
I know.
Yeah.
Because the nowadays we have to use the MR perfusions because the radiations. Except you use a CT perfusion. Mostly the CT perfusion most rapid because the patient will send to the department and then we do the prepare the patients and then do the PET scan and then the contrast with the two phase, the CTA and the perfusion. So more faster. Okay, thank you very much. No more question. Thank you.
Okay, thank you.
I think for stroke patients in Taiwan, I think multi-phase CTA is most popular in Taiwan now.
Yes, I know, but Macau also have a CT scanner with the multi-phase software, but they don't like to use, just only to use a CTA enough.
Yeah.
Depend the radiologist and the neurologist, different countries, right?
Yeah. Okay. Any question? Any other question? Okay. I just have one question for Mr. Chen. I think as we know, I think Rapid is a pay-to-use software. So it's compared to the post-station software of the instructing itself. So what are the advantages?
Okay. It uses time to process the data, including the CT perfusion. It needs someone to do the primary process. Also, 3D CTA image, process CTA image by CT workstation to calculate time for the cerebral blood flow, as well as the time needed for doctor to provide their determination. There are all time-consuming tasks, not to mention that the time for communication should also be taken into consideration. The rapid takes only 5 minutes, or even short time for the time of completely the exam for patient to automatically send to the server and completely the image analysis. The analysis result they will be delivered to the doctor who is on call duty by ml or real time, and can support the doctor for their initial judgment or the positivity, the analysis. So could save time and be more defenses. We cannot is how long it will take from a patient being taken to the hospital. So that but it's for sure that the short time we take the better for the patient treatment and prognosis. So the raptor will make the short time for give the doctor primary judgment. That's the raptor advantage.
Okay, I see. Another very important traction. Yes. So the patient should pay the rapid test by themselves.
And no.
So who paid that?
Hospital. That's free. Yeah, right. That's
okay.
Free.
That's great. That's
free.
Okay. Any other question?
Yeah. A question. Yeah. From me. Yeah. First of all, for Mr. Yu-Xuan, how to reduce the artifact for MRI in abdomen, especially for Crohn disease. And then for the second presentation, Mr. Chen, yeah. What actually the gold standard to determine sensitivity and specificity in LVO AI? Okay, you can catch Mr. Lee.
Sorry, can you repeat your question because I have the time?
Yeah. So how to reduce the artifacts, yeah, especially in the abdomen MRI in Crohn disease. This is for you, Mr. Lin, and then for Mr. Chen. What is the gold standard? Yeah, the gold standard to determine sensitivity and specificity in LVO.
I think the LVO one is not from me. It's
Mr. Chen, I think the second person there.
Yeah. Okay.
Oh, yeah. Gold standard, right?
Okay.
So maybe Mr. Lin for inscription.
It's me? Okay.
Okay.
Sure. Okay. We will let the patient let he hold breathing, and we will also use the buscopan and use the two-phase sequence to obtain our abdominal imagery. So these all program sequence. So
yeah, it is just a single breath hold, something like that. Yeah.
Yep, just that's all.
Okay.
Sorry. I think there are different way to do MRI Crohn disease examination. So in the hospital I work for, we will do the MRE. We used to dynamic sealing T2 image, two-phase, or maybe for Philip TFFE. This sequence. So we will make a dynamic image for and then so the patient in the hospital I go forward, we will free breathing, and take a series of dynamic image, so we can see how the interest in the motion, so we can to make sure what's wrong and what's area and something wrong and something we have to check more detail. So this is in a hospital.
Yeah. Okay.
So
yeah.
The second question for
Mr. Chen.
Yes. The alluvial, the gold standard is by the entry result is determined by the senior radiologist. So the gold standards, because the research is the retrospective study, so we know the result.
Okay, so the expectation from the senior radiologist, yeah.
Yeah, senior radiologist.
Okay, okay, all right.
Thank you.
Really, a lot of questions from chat box. Oliver, have a look at chat box.
So, any other question?
Many questions from the chat box, Italy.
May I ask one question for the third speaker?
Okay, please.
Prostate cancer?
Yes.
Yeah, I'm Nelson from Hong Kong. Actually, I just want to know much about the arrangement in Taiwan. If in case the MRI, the prostate, you mean the CNM software, and confirm the patient is highly suspicious of the prostate cancer, will the patient will be arranged for the biopsy to reconfirm that the cell is malignant or benign or what else? I just want to know more about that, or just pass the case if it is confirmed already in MRI and then pass to the oncologist for the treatment. Okay.
Yeah. So honestly, I seldom practice in Taiwan. I did this review when I was in Scotland. However, personally, I don't really think they started to use this technique clinically because, well, you have to every types of software, and especially for artificial intelligence, this kind of software, it needs to be approved by FDA, or it needs to be approved followed by certain regulations that the government have. So if this is really started to be used, and the company who provide this service have to pass this. Or otherwise it have to be used as the research purposes. So which means that we won't really take this as the standard that we just take the result. I don't think they do this as well. They will always refer the patient suspects to have prostate cancer. I do believe that they would just let the patient do the biopsy. But there's a possibilities in the future that if we really have this technique and it's being approved by government, as I just mentioned, we can really fasten the whole process. The patient probably won't really wait for that long to be able to be tested. And yeah, you can get instant results from it, and that will be good for everyone, like from the hospital side as well as the patient side. Yeah.
Thank you.
Thank you.
In Italy, you see in chest box a lot of Western from Oliver.
So, have any other question?
You look in the chat box a lot of Western from Oliver, Italy.
Okay, I see. Okay, so we have a question from our audience. So, and the question is whether only vascular injection for reduced artifact or required fasting or abating the in testing for period preparation. Okay, so Mr. Lin.
Sorry. Can you repeat your question? I didn't see in just time. Sorry, can you repeat your question, Chairman?
Okay, I think the question has been slow. Okay. Okay, it's okay. No problem. So, have any other question for our speaker? Okay, I think this is an excellent opportunity for our members to have experience in international affairs. And it's also provided a good platform in clinical experience exchange. So I think we wish this platform could be continued, and we will still join and contribute for this. Okay, so before the end of this meeting, so I think we would like to invite President Du Junyan to make a brief summary of the meeting tonight.
Okay, I believe that all of you have well done through the discussion. Finally, on behalf of the TAMRT, I would like to express my appreciation to all of the participants for taking time out of the busy duties to attending this seminar. And I would like to close my remark and officially announce the end of this seminar. Thank you.
Next, BG, introduce something. Introduce some. Next, BG.
Yes, so again, thank you very much, President Chun Yuan-Tu and the CPD Program Moderator Cheng Wei Li. In closing, please welcome President Wan Shibu Nelson of Hong Kong Radiographers Association, HKRA, for his message and invitations.
Thank you, Pichi. And I'm Nelson from Hong Kong, and thank you, the TAMRT, for giving us a very fruitful night. And I can say the next event will be hosted by Hong Kong, and the date is 23rd of May, and the time is 4 p.m. Hong Kong. Please mark it down and hope to see you all again. So stay healthy and